Well, good evening, everyone. So just as she said, I'm an emergency EMS physician. So what that means is I'm really good at identifying things that are going to kill you. And I'm also really good at setting up healthcare systems outside of hospitals, otherwise called pre-hospital care. And so when I ran this virtual emergency service program throughout the country, we launched in DeKalb County and we grew it from Washington State to Washington, D.C. One thing we saw over and over again was there were many calls for seniors. And it wasn't like our seniors needed the hospital system, but they also needed more than just like take 2 aspirin, call your PCP in the morning. And so oftentimes the only place to go was the emergency department. And that was why we started Green Dot Health. So with Green Dot Health, what we do is we democratize access to ER doctors. So instead of requiring you going to the emergency department, paying a $1,200 facility fee, waiting 4 to 6 hours to be seen, getting exposed to whatever infectious disease flavor there is of the month. So right now, flu is just rampant throughout Atlanta. So instead of all that, instead what we do is you can pick up your phone, you can call or text and speak to an ER doctor directly. And then not only do we pick up the phone, of course, and answer you and write prescriptions and provide you reassurance as needed, but more importantly, we arrange in-home lab draws with no out-of-pocket cost to you if you have private insurance. That includes Medicare, Medicaid, And then if you don't have insurance, we'll give you the cost that it is to us. So for example, like a blood count is $3, and that's something that we would give to you instead of adding an upcharge to that. We'll also arrange mobile imaging. So that's X-ray, ultrasound. CT MRI is not mobile yet, but when it is, we will get it to you. For now, we arrange outpatient CT MRI within a 5-mile radius of your home, and we own that entire care spectrum. That's the whole point. And so that's what we do with Green Dot Health. But today, what I'm going to talk to you today about is things that cause our seniors to end up in the emergency department regularly. So of everyone in this room, how many have been to the emergency department in the last year? Yeah, a lot of people. Yeah. So actually, every year there are more visits to ERs and urgent cares than there are people in the United States. And that's a weird sort of thing to think about, because more people are going to these places to see doctors than they are going to their PCPs for annual wellness visits. Part of that is a systems problem, right? Like the average time to see your PCP is about 21 days. And that's on like the better end. Most of us, if you call your PCP, it's like 3 to 6 month wait. And so you just can't wait that long. And that's why you end up going to these places where there's unscheduled care, like urgent cares or ERs. And so the most common cause for seniors to go to the emergency department is falls. So of those of you who raised your hands, was it any of these related to falls? Yeah, so 1 in 3 seniors falls every year. And of those falls, 1 in 10 will end up in a serious injury, which means fracture or a head injury that requires sometimes even hospitalization. 800,000 seniors are hospitalized every year for falls. So the first thing we're going to talk about is falls, because that's the #1 reason why our seniors end up in the emergency department. And then we're going to talk about urinary tract infections and pneumonia. So the big 3, okay? First, we're going to talk about what they are. We're going to talk about how to prevent them, and then how to assess and treat it when it does happen. So when it happens, you're not going to worry or freak out. You're going to sort of have a methodical way of figuring out how to deal with this. Okay, so for those of you who went to the emergency department for the fall, how many of you were discharged home with like physical therapy or occupational therapy orders? Okay, some of you are awesome. Because the biggest reason for falls as we get older is, 1, we have something called immunosenescence. What that is your immune system ages just as much as we do, just as much as our body does, and so do your nerves. And so this whole process of like getting up and walking actually requires like a lot of coordination between different nerves. It's not just the nerves that sense your balance, it's the nerves that sense your feet. It's the nerves that then connect it to your brain and tell you where your body is in relation to all that. And so as you get older, these things don't always connect so well. And so that is one of the leading causes of falls. This causes imbalance. It causes you to feel like, I'm scared. I don't really feel steady on my feet. And so a way that you can assess yourself even, or those that you love, to see if you're at risk of falls is something called a timed up and go test. So what that is, it's really simple. So, you take a chair and, obviously be there with your loved one. Try not to do it alone because we don't want anyone falling while we're doing this. But essentially you're sitting down on a chair and then you stand up and you walk 10 feet. You turn around, you walk back, and then you sit back down. If that takes you longer than 12 seconds, you're at risk for a fall. And so that's a really nice way to be able to assess your loved ones or the people that you're caring for to see, are you at risk here? And if you are, then physical therapy is something that's really helpful, because physical therapy is all about strengthening the muscles to get you steady. So really what they'll do is like stand up, sit down exercises to help you get steady here, and then turning and transferring is another one. So they just sort of break it down and then train your body to be able to do that. And then of the hip fractures that happen every year, 95% of them are in our seniors. And that's because when we fall, we oftentimes don't really know how to fall. And so we don't really brace our bodies, and then we'll oftentimes fall on the left hip or the right hip. When you have a hip fracture, your risk of dying within the next year is about 68%. So it's really high. And so this is the reason why we want to prevent these as much as possible. So that includes not just timed up and go, doing physical therapy, occupational therapy. The second one is going to a podiatrist. So that's a doctor that specializes in feet, to check your feet, to see, can you feel? And if you can't feel, what type of footwear do we need to give you to help prevent you from falling? And, you know, spoiler alert, heels aren't good for you. Not that any of us needed to know that, really. And then thirdly is you have to assess your hearing and vision regularly. So if your loved one hasn't had a hearing or vision test recently, that's also important, because if you can't understand depth, because that also requires your ability to see very well. So if you can't understand depth, then you'll misstep and then you'll fall. So these are three major things that you can do. So timed up and go, call your PCP, or if you have a service like Green Dot or Concierge Doctor, PT/OT. And then hearing and vision testing regularly. And then third, podiatry, for them to check out your feet and see if you need special footwear and see if there's anything else that can be done. Now, if you're noticing already that you're having trouble feeling on the bottom of your feet, then those are things that also will trigger, okay, well, what else is going on here? This could be related to Parkinson's. It could be a B12 deficiency. It could be a vitamin. I mean, it could be so simple. So it's one of those things that you want to check regularly. So let's say a fall has happened. Okay, so you're home. So how many of you are caring for someone at home? Okay, wonderful. And then anyone in like a facility or in a community? Okay. So communities, usually have a rubric for how they assess these. So, but if someone fell at home, the biggest thing first is to make sure that they're okay, right? So if they're like you go and you say, hey, are you okay? And they can talk to you, awesome, we've got some time. If they're not talking to you, that's a call 911, and then we'll come back here later. So always make sure you call for help first. So if they're alert and they're talking to you, then the next step is to figure out, well, are you feeling dizzy right now? Where is your pain? So if they're too dizzy to stand up, you don't want to get them up again, because they're just going to fall. So you'll keep them on the floor and call for help too. But if they're not dizzy and they're not in a tremendous amount of pain, then the next step is to try to see if they can stand up on their own. And that requires a lot of assistance. But what you're checking for here is if a bone is broken, you're not putting any weight on it, right? So if you're laying on the floor and you get up and you're not putting any weight on it, that's another sign that we have to go to the emergency department, or depending on what your goals of care are. So for example, we took care of a resident in a senior living community recently whose goals of care, she was a former nurse. So she was like, listen, I'm not going to the ER and I don't care what you say. And that's okay. I'm the same way. That's how I would be too, just because I've lived in this space so long. But so for her, she didn't want to go. So her goals of care were just make me comfortable. So in that scenario, what we did is we called hospice and palliative care and had a very frank discussion of like, I can tell just by looking at her that she had a hip fracture. But we had that very frank conversation of what this means, right? That we're not going to be able to walk anymore, that there's going to be a lot of pain, and the chance of passing away is higher. And this was a patient who was in her late 90s, and she was like, that's fine. So we started hospice, we got a hospital bed, and within 24 hours, she got to stay home instead of going to the emergency department, and we started pain medicine, and we got round-the-clock care for her. So it just depends on that goals of care, too. So, sometimes the knee-jerk reaction is call 911, let's take them to the emergency department. But if that's not within their goals of care, then think about, what are some alternatives that we have here to help meet her or him where they're at. So first, are they responsive? If they're responsive and interacting with you, if they're not responsive and not interacting with you, call 911. And 911 will keep you on the phone. So I don't know if anyone here has called 911. It's actually kind of frustrating because you're having an emergency and they make you repeat a bunch of stuff over and over again, which is by design. Because sometimes in the worry of all that's happening, you can sometimes give the wrong address and the wrong phone number. And believe it or not, it happens a lot. So that's built into the algorithm there. So once you tell them that they're unresponsive, they will walk through with you next steps. So they also will help you while you're on the phone. So I don't want you to feel like, oh my God, what do I do here? You're not alone. There's always someone that's a call away for you. So if they're not responsive and not talking to you, call 911. Secondly, if they're too dizzy to get up and they're unable to bear any weight on their legs, then that's another sign that we got to call 911, and then or talk about goals of care and see if we can get some secondary help. And then third, once all that's done, let's say they're getting up and they're walking, they're sitting down, then we need to figure out, why did you fall, right? And sometimes it's just straight mechanical, like I tripped over this thing on the this curled up rug. That means we got to get rid of the rug. And I know that sounds really like intuitive, but it happens a lot. It's like the same rug they've tripped over like 3 times. Just roll that bad boy up and throw them out. Other things too is to think about the clutter in the house. So if it's mechanical, just clean up all the clutter. This is where OT and even changing spaces would be really helpful, right? Just getting some other pair of eyes in there to come help you optimize your environment to prevent falls. Occupational therapy will help with that as well. And then thirdly, if it's I'm feeling sick, I've got fevers, I've got chills, and there's something else going on here. It's not, the fall is actually a symptom of a bigger problem. And that's sort of our segue into infections. So before I move on, does anyone have any questions? I know I threw a lot of information at you. Yes, ma'am.
On falling.
Yes.
Is part of it to have them learn, or could OT teach them how to get up?
Yes.
Okay.
Yes.
That's part of our problem is my mother-in-law falls.
Mm-hmm.
She figures out how to fall, but then she's stuck on the floor.
Yeah.
And she lives alone.
Okay.
So I never thought about OT to teach her how to get up.
Yes, OT can help, PT can help as well. It's just strengthening all of those, the core muscles and the abdomen, just making her stronger so that she can get up. And then the other thing too is you can think of like, does she have any like caregivers that come into the home at all or anything? Like twice a week? Okay, and it's like never when it actually happens, of course. Yeah.
It's like the minute they leave.
Yeah, and so the other thing to think about is the handlebars. So if you can install handlebars, so she can, if she can't actually like get up, she can crawl and then pull herself up. So that's another opportunity. And then, and that's something that Mobility Plus I think can help with as well. And then same thing with like beds. Is that me? That's not me. No, that's the. I'm sorry, guys. I was like, it's like, is my phone ringing? Okay, sorry. My son had surgery and he hasn't been sleeping, and so it's just been like a really hectic 4 days. So sorry, my brain is a little kaput. And then the other thing to think about too is like bed. I don't know if like falling out of bed is another big thing, right? And obviously if you've got sharp corners around the bed and you fall and you sometimes will get lacerations or head injuries from that too. So think about the height of the bed too, so that if you do fall off, it's not something that could kill you or cause brain bleeds. And that's something as well that Mobility Plus and Changing Spaces can help you with. Yeah, absolutely. What else? Yes, ma'am.
So falling and hitting the head on a blood center, is that an immediate go to the ER?
Yeah, you know, it's okay. So it always depends. The answer is always it depends, right? Like, not to quote Star Wars, but like only a Sith thinks in absolutes, right? Like it's like, you know, it just depends on their goals of care. So for example, we have someone who fell the other day, was on the golf course and fell, was on blood thinners, and he was just like, I'm just not going. You know, like come what may, I'm just not going. But we can meet him where he's at and say, okay, these are the risks of you not going. You could have a brain bleed, which could result in seizures. It could result in death. It could result in cognitive decline. That's the risk. If you accept those risks, what we can do is arrange an outpatient CT scan within 3 hours. And so that's what we did. We arranged a CT scan. His wife took him, because it was mostly his wife who was calling us, being like, somebody talk sense into this man, you know? And so that's where it's meeting him where he's at and saying, okay, if this isn't something that you're willing to do, here's an alternative. But by and large, like if you fall and you hit your head and you're on blood thinners, that's almost always an ER visit, unless we can get a CT scan within like an hour, and we will assess you. So like, for example, if you've fallen and hit your head and you're like sleepy, your eyes are closed, you're complaining of a 10 out of, that's it. We're not messing around with that, because you're probably going to need intervention. But if you're like totally alert and oriented and you're just like, I really don't want to go, this isn't something I want to do, then we can talk about it. But so it's never like you should always maintain your autonomy. Just because number one, like the outcomes are always better when you feel like you have some say in what's going on. And then two, it's about feeling like you are in control. And that's a big piece for our seniors. And I mean, all of us, right? Like all of us need to feel like we have some sense of control in the world. And if we don't, it creates a lot of anxiety. And as you get older, that sense of autonomy begins to slip, right? Because you've got your children who really care about you, or loved ones who really care about you, trying to make you feel safe and comfortable at home. And sometimes that means losing the ability to drive, and, you know, losing the ability to walk on your own and requiring a walker, which oftentimes is like I'm sure a lot of you in here have experienced that, where your loved one is like, I'm not using a walker. Right, but you know they need it, because it ultimately ends in these falls. So just something to think about too, about like sort of encouraging autonomy and meeting them where they're at. But yes, by and large, that usually means that, unless we can arrange a CT scan very quickly. Okay, any other questions? Okay, well, we're going to move on to urinary tract infections. Okay, so urinary tract infections is actually the second most common cause of coming to the emergency department. The good news about UTIs is, like, although they are an infection, they're not nearly as bad as something called pneumonia, which is an infection in your lungs. So UTIs can often, so a urinary tract infection is an infection that's either in your bladder or in your kidneys. That's all part of the same urinary tract. If a bladder infection doesn't get treated, then that infection can then move up to your kidney. So it may start as like, oh, I'm having some trouble urinating, or I'm peeing more frequently than usual. And usually the trigger is, mom is getting up a lot at night to go to the restroom, and she doesn't normally do that. And that and usually they may culminate as a fall, but the fall is not really the problem. It's the urinary tract infection that precipitated the fall. So that's why a really good history is really important. So anyways, so urinary tract infections are, I'm urinating a lot. I feel like I've urinated, but I still need to keep urinating. But then when I go, like, only drops come out. It burns when I urinate. I'm having some lower abdominal pain, or I'm having some flank pain and fevers. Now, once it gets to flank pain, which is where your kidneys are, so right back here, and that's not like lower back. So when you think about like your hip space, that's not where your kidneys are. Your kidneys are higher up than that. So if it's flank pain and nausea and vomiting, that makes you think that this is a kidney infection. And usually once it gets to the kidneys, your risk of that infection spreading to your blood is higher. So that's the other word for sepsis. So sepsis is an infection that starts off in one space and then moves to your blood, and now the infection gets all over your body. Sepsis is one of the leading causes of death. So that's why when we identify infections, we want to treat them without going overboard, right? We don't want to give antibiotics for everything all the time, because suddenly you're starting to breed a superbug. So urinary tract infections, those are usually the symptoms. Now, as we talked about, as you get older, you get immunosenescence, which is a fancy word for just as your body ages, so does your immune system. And then your nerves also change. So you may not even feel those symptoms. So as our seniors get older, it's not even I have urinary symptoms. It's usually like, I've noticed mom's not eating enough, mom's sleeping a lot. She's a lot more confused. She's starting to kind of see things that aren't there, which in the setting of dementia can feel like, oh, maybe this is just dementia that's worsening. That could be the case, but that's always a diagnosis of exclusion. It's always, let's rule out everything that's reversible before we call this worsening dementia. And it could present as confusion and falls. So if you have any of those symptoms, that's when we would start looking to check for a urinary tract infection. So is anyone here, actually, I don't want you to raise your hand because that might feel a little weird, but so urinary tract infections disproportionately affect women, especially obviously for our seniors, they're postmenopausal because of the lack of estrogen. And so oftentimes a prevention strategy for urinary tract infections is to start vaginal estrogen. Another thing that we can use to prevent urinary tract infections is hydration, because you just want to flush out whatever is living in there. Obviously, that becomes a problem as we get older, because just as we talked about, you don't feel as well, you don't feel your body as well, you don't feel thirst as much. And so just like with our toddlers, where we're like, hey, you chase them around to drink, it's the same thing sometimes with our seniors. We want to encourage them to drink at least 6 to 8 glasses of water a day. And there's some two other things that people will use to help prevent infections. That's D-mannose. It's available over the counter. It's basically branded by Azo, which is a piece of a component of cranberries. And there's something else called methamine, which your primary care doctor can prescribe to you, or whoever your physician is that's taking care of you can help prescribe that. The evidence is pretty mixed. Yes, ma'am.
Are those prescriptions?
The Azo, the D-mannose is not, but the methenamine is. And you know what, guys? I have handouts, and I will email them to you guys as well. That will include all this information. I'm sorry, I should have said that up front. But I'll email all this information out to you guys. But so methenamine is a prescription, and the jury's out. Like, we don't really know if it's helpful, if it's going to prevent infections. We've got pretty mixed results, but it's got a pretty low risk profile. So most people tolerate it really well. And so for me, if that's something that you're battling regularly, that's something that I would try and start. And if it doesn't help, then you don't have to continue. Yes, ma'am.
Can you just explain a little more of the method of that other medication? Like, what's it?
Oh, yeah. Yeah, great question. We don't know.
Okay.
Yeah, that's why the jury, we're not entirely sure how it works, right? With D-mannose, because it's a piece of like a cranberry chemical, what it does is it helps increase it's going to sound a little gross, and I don't mean it to sound that way, but it helps increase the mucus production, which prevents bacteria from sticking. So that's what we think, but we're not 100% sure. I think once we understand the mechanisms better, it then will help us target it better. But that's what we think with these two things. Vaginal estrogen 100% increases mucosa production, which is why we use it for postmenopausal women who need it, who don't have any contraindication, meaning they don't have history of breast cancer, don't have any history of hormone-related cancers, then we can use it. And it's localized. It's not a pill. So you just put it in the area that it's affected at, and it's less risky. Okay, so those are prevention strategies. So hydration, you can use some over-the-counter medications. If your loved one is in diapers, just as much as, with children, it's the same. If you've got stool in your diaper and it's sitting up against your urethra, that's another cause for infection. So you want to keep the adult brief as clean as possible. I know that's really hard. So if anyone here has a loved one that wears adult briefs and you can keep their bottom free of rashes, cheers to you, because it is very hard to do that. So if they're incontinent, making sure that we're cleaning them as much as possible. And then, so there's something called continence training. Has anyone here done that? So it's essentially having your loved one sit in the restroom every 2 to 3 hours. And so that way they're not getting up at night to go to the restroom. And so that's a way that you can help them sort of prompt their bladder to empty. Because if their bladder isn't emptying and that urine sits in there, it can get infected. So those are strategies that you can use to prevent urinary tract infections. Now, how do you recognize urinary tract infections? So I love urine dipsticks. They're available over the counter. You can buy them on Amazon. We actually, so when a member signs up for Green Dot, we'll send a box to your home that includes a pulse oximeter, a blood pressure cuff, and urine dipsticks, because I love those things. It's a really easy way to screen for urinary tract infections. And there's something called asymptomatic bacteriuria, which is just a fancy word for saying that there's bacteria that's in your urine, but it's not causing problems, which is why the history is the most important part. So right now, if we tested everyone's urine in this room and you're not having urinary tract symptoms, or you're not more sleepy or confused or not eating, whatever your symptoms may be, if you're not having any symptoms, then you don't have an infection. It's just bacteria that's living there, but it's not invading into the space. And so it's not one of those things you want to just check regularly. It's if mom's not eating well enough, mom's not sleeping well, mom's starting to complain of seeing things on the walls, things like that. That would be the reason to pull out the urine dipstick and do a quick check. Yes, ma'am.
Are those the same as the over-the-counter ones, or these are a little higher grade, more?
Yeah. So we'll use the medical grade version of it, but it's just as effective as a screening tool as the over-the-counter ones. And so you can just go on Amazon and use it. You dip it and then you put it on a piece of, first you have to collect the urine, which is maybe the hardest part. So first you have them pee into a cup and then you dip it and then just compare it to, they'll give you a control that'll show you what infection looks like. And then you put the dipstick next to it, which is a bunch of different colors, and you match it up. Or you can take a picture of it and send it to your doctor. That's another thing you can do. But that's a way to screen for urinary tract infections very easily, because again, urinary tract infections, when they go untreated, can go up to the kidneys, which can then go into the bloodstream. Any questions about that? Yes, ma'am.
Could you go back to what is it about the UTI that will make a person fall? Is it the tiredness, the sleepiness, and just? Yeah, so it's the infection will make them weaker. 2, going to the bathroom all the time increases their risk of falling, because especially it happens at night where you can't see very well. And so that's another great point. Thank you for bringing that up, is if you guys have seen those outlets where they have the lights in them, that's another great thing to use at night, so that your loved one, when they're getting up, they can see better and not trip over things. So yes, that's what it is. And then, again, the elderly don't really feel like their nerves don't really work as well as they used to, so you don't really feel the urinary symptoms. Instead, you just feel a little agitated. If anyone has had urinary obstruction in here, what it does is it triggers, so when your bladder gets big and distended, it doesn't trigger the nerves around there. It triggers something called your sympathetic nervous system, which is that same fight or flight response. And so when it gets infected, it can trigger that fight or flight response, and it doesn't really make sense, right? Because they're obviously not in danger, but they feel like it, and that can create this agitation, anxiety, we don't know what's happening, or even psychosis.
So that's what that mental, the confusion and the agitation, that's all because of that fight or flight?
So that, and also just the
the fact that they're not feeling as well, like that malaise and that fatigue can just come from infection in general. But yes, the confusion, the agitation, that's that sympathetic nervous system that's just firing off. And it's hard, you don't localize it, right? When you have fight or flight, it's just sort of everywhere. It's that same concept. We call it encephalopathy, if you want to know the $5 word. Okay, any other questions or concerns here? Whoa, you guys are doing great. I'm like lecturing you so hard. Does anyone like, if you guys need a break, let me know. And otherwise we'll go quickly into pneumonia and then I'll give you guys a break. Okay, so this is like perfect for this season because we're going into respiratory season. So although pneumonia is not as common, they're both common, like they happen frequently, but pneumonia happens as half as frequent as urinary tract infections, but they're far more dangerous. So they're the leading cause of bacterial infections that require hospitalization and one of the leading causes of death in our seniors. So it's really important that we recognize pneumonia early. And here's the thing with pneumonia, just like UTIs, it can present really atypically. So first, before we even get into that, let's talk about prevention. I know this gets politicized some, but the reality is that vaccination helps prevent pneumonia, whether it's your influenza vaccine, your pneumococcal vaccine. COVID, there's not like we haven't had like a lot of studies for COVID to really show that. So that's sort of, the jury is still out regarding COVID-19. I always will recommend vaccination, but if you feel strongly about that, evidence doesn't pan out just yet. But influenza, pneumococcal vaccinations prevent pneumonia. It'll save your life. So make sure you get vaccinated. The second one is if you're going out into spaces with lots of people, wear a mask. It's the easiest way to protect yourself because pneumonia is spread via droplets. What that means is like right now as I'm talking, all of us, it's gross too. I mean, in the end of the day, we're all animals, so we could just say it. But like when you're talking, spit's coming out of your mouth constantly. And that little micro droplets of spit, if it ends up in your mouth or in your airway, you can get infected. So if you wear a mask, it's the easiest way to protect yourself. And then washing your hands. So like just make it a habit. Everywhere you go, wash your hands when you get home, wash your hands before you touch your mouth or your face. That's a little bit harder. It takes a lot of behavior changes. And of course, in our seniors, it's a lot harder to kind of implement that, but just something to keep in mind. And then the fourth one is, no smoking. No alcohol if you can avoid it. Some of the people that we care for have alcohol use disorder, and that always predisposes them to infection. Same thing with tobacco use, so just something to keep in mind, or vaping, or whether it's whatever you're smoking, whatever it is, it's toxic to your lung space. It impairs the mucosa and impairs your ability to heal. So those are ways that you can prevent pneumonia. And then once you get pneumonia, how do we identify pneumonia early? And so again, same concepts that we see in all these in these other spaces. Our immune system ages, so it's harder for it to respond and mount a response. So oftentimes our seniors don't mount fevers. When you see a fever, that's oftentimes kind of like the end stage. So you want to be really cognizant of like when there's a cough, when did that cough start, right? Some people live with a chronic cough. They're coughing all the time. But if you notice that their coughing is getting more frequent or they're coughing up things, then that's a worrisome for developing pneumonia. The other thing too is actually this runs in my family. We have really bad dysphagia, which is impaired swallowing. And so if you notice that your loved one coughs a lot with eating, that's a risk factor for pneumonia. So you want to make sure that they're evaluated by their primary care doctor or whoever's taking care of them to do something called a dysphagia screen. And that's basically like a barium swallow study to see if they're aspirating, which is where you're inhaling food into your lungs instead of it going down your esophagus. When food gets in your lungs, it becomes a nidus of infection. So making sure that you're screening for dysphagia, making sure you're getting immunizations, making sure you're wearing a mask, washing your hands, these are all important things. And then identifying early if there's a cough, is the cough changed? Is the nature, frequency, character of it changed? And then two, if you're noticing, this is like just anecdotal, there's no studies on it, but I have noticed that in my elderly patients, when they're sleeping a lot, it's almost always pneumonia. So if you're noticing same thing, like confusion, sleeping a lot, change in behavior, activity, that could be signs of pneumonia. The easiest way to test for that,
A chest x-ray is the number 1, 2, and 3 way to check it. There's actually a few mobile x-ray providers here in Atlanta that take Medicare, so they can come out and do an x-ray within 24 hours in your home. You just need a physician order, but that's a way to kind of to get it done and get it screened. And then also a pulse oximeter. Does anyone know what that is? Okay, look, everyone's shaking. Everyone's, one of the things that came out of COVID was everyone has a pulse oximeter. So this is what a pulse oximeter is. I didn't even open it up, but this is a pulse oximeter. So what it does is it checks your oxygen level and it checks your heart rate. So if you're putting it on your loved one and you're noticing the oxygen level is dropping, that's a sign that this could be pneumonia. Or you're noticing the heart rate's above 100, that's another sign that it could be pneumonia. So that's an easy screening tool to have at home. And then once we identify pneumonia, then the treatment is antibiotics, breathing treatments, incentive spirometry, and very close monitoring. Because even if you start treatment, it may not change the outcome. Yes, sir?
Is there an app for your cell phone that can tie into a pulse oximeter?
Yes.
That would warn you,
Oh, yeah.
just blare out?
Yeah, right? There are things like, for example, iHealth is one that's available on Amazon where it's like Bluetooth connected. It's not continuous though, like your point of like, you'd be great if your Apple Watch does it. It's just not FDA approved for it yet. But that would be, does anyone know if your Apple Watch does oxygen?
Used to, and I think they had to take it away because of
The false, yeah. So no, not yet. But if you keep your pulse oximeter around the house and you're feeling funny, then you can always put it on and check to see.
What if you're asleep?
Yeah, if you're asleep.
You need something waking you up.
Yeah. Most pulse oximeter, actually no, it depends on how long. But like, for example, this pulse oximeter that we use, you can keep it on, and then if your oxygen drops, it starts beeping. But it's not designed for continuous use. So you'll get a lot of false positives, excuse me. So not yet. Yes, ma'am.
How do you get one of those?
So you can get them online. So the one that we send out in our boxes are the only FDA approved pulse oximeters. They're just pretty expensive. So like an Amazon pulse oximeter works too as an initial screening. The only FDA approved pulse oximeter on the market is something called Oxalign, and I'll send it out in the email as well. So Oxiline, but they're like $100, so it's a little expensive. But you can buy one on Amazon for $15 and use it as a screening. Yes, ma'am.
How often should you get the pneumonia vaccine? Is it like one and done, like shingles?
No, so there are some boosters that you can get as well. To be honest with you, I'm not a primary care doctor, so I don't know the whole vaccine schedule. But I know that there are boosters, and there's also for shingles too. There's a vaccine that I think everyone should get as well, because shingles is terrible when it hits. So no, I don't know that specific. Yes, ma'am.
Is that the RSV? What is that?
So RSV so pneumococcal vaccination prevents you from a bacterial infection.
That's the pneumonia.
That's the pneumonia. Now RSV can give you a viral pneumonia, and RSV can also so flu is a viral infection, COVID is a viral infection, RSV are viral infections. All three of these can be dangerous if you get them.
So those shots.
Yes, those shots can prevent you from getting a viral pneumonia. Okay. Okay. Yeah. So it's although it's a viral, it's a vaccine that prevents viruses. Those viruses can still be really dangerous and cause pneumonias. The worst thing about viruses is we don't really have great treatments for them. So it's almost like, I'd almost prefer a bacterial infection over a viral infection, because once it gets bad, it's really hard to treat.
And pneumonia, that's viral.
It can give you pneumonia. So there's different types of pneumonia.
That's what I was just going to
Yeah.
say. They said there are different. The immunization that was for one type.
That's right. Yes.
For the bacteria.
Yes.
Bacterial.
That's it's against pneumococcus. So it's one bacteria, but it's the most common bacteria that causes pneumonia. And then RSV, COVID, and flu, these are, just to get in, we can nerd out a little bit about vaccines here, but like vaccinations, they're oftentimes viruses mutate a lot. And so oftentimes the reason why we have new vaccinations every year is we have to create a vaccine that effectively targets whatever currently it's mutated to. And so every year, for example, for the flu vaccine, we will look at the southern hemisphere because they have winter before us, and we'll see what's the most common strains that we're seeing in the southern hemisphere, and then we'll use that to target for our flu season in the northern hemisphere. And every year our flu vaccine is not 100%. It's like last year I think it was 30% effective. This year it's a little bit better. It's about 50% effective. So there's still a risk that you could get it, but to your point about it, it's constantly mutating, which is why we have to do it every year.
Well, when you think about, depending on where you are in life, they talk about the risks, but to me, excuse me, the older you are, the less one should be concerned about the risk, but to try not to have you go through a serious illness or whatever.
Yeah, exactly.
And so to me, that's the reason I take those. Because I think that where I am in life, I want all the help I can get.
Yeah, absolutely. And we sort of talked about immunosenescence, right? As you get older, your immune system also ages and doesn't remember. And so this is a way of reminding your immune system, hey, this is a bad thing. We need to identify it and kill it before it kills us. Okay, well, you guys, congratulations. You've had a full lecture on infections and falls in our seniors. Yes, ma'am.
Well, I would love, and they would probably also love to hear more about how Green Dot works. And instead of going to a traditional ER,
yes,
we have an acute medical event happen, or we just fall and hit our head or whatever. What do we do? We call you?
Yes. Okay. So you sign up for Green Dot at www.greendothealth.com. I will send this all out in an email. And then once you sign up for Green Dot, we have you schedule a meet and greet appointment. We're an entirely virtual practice. So we don't come out and do house visits. There is an additional charge for it, but all of our charge is 100% covered virtually. So you have a meet and greet appointment with us. We send you a box that includes pulse oximeter that I showed you here, a blood pressure cuff. It includes some wound care supplies just so that if you fall, there's something there to take care of it. And then those urine dipstick tests. If you have a history of diabetes, then we'll send out a glucometer as well. And then we have a meet and greet appointment, because what we don't want to happen is meet you for the first time when something crazy is happening, because you may not even remember all the things, and oftentimes you need a caregiver with you. So we'll get all the history, learn everything about you, so that in the moment that you reach out to us later, we're not going over basics. We already know who you are. And then once you need us, so the reality is when something happens, your first thing you're going to do is pick up your phone and call 911, right? And that's fine. You can pick up your phone and call 911. As former associate director to Grady EMS for 8 years, I can tell you the response time is supposed to be 15 minutes. It's closer to like 30 minutes. So you can call for help, but you can call us right after. So you don't have to download an app or log into a portal. We're just a phone call. So you pick up your phone, you can call us. You're immediately connected to a board-certified emergency physician. And then what we'll do is we'll send you a link for a video visit, or we can talk to you over the phone, depending on the need. So if you're like, I'm having trouble breathing, it's best for us to see you. And then what we'll do is sort of prompt you through methodically how to assess this. So, hey, I'm having some trouble breathing. Okay, let's pull out your box. Let's put on your pulse oximeter. What does your oxygen level look like? What is your heart rate? So we sort of assess you in the exact same way that you would be assessed in the emergency department. And then once we assess you, if we say, okay, this isn't an emergency, we can take care of this from home, then what we'll do is we'll call you with in-home lab draw. So a nurse will call you within 24 to 48 hours for an in-home lab draw. We'll arrange mobile x-ray or ultrasound if you need it. If you need a CT or MRI, we'll call you with like, here's the place to go, and this is the address, and this is the time that you can go in to be seen. And then we'll write you prescriptions, and we'll also loop in your primary care physician. So that way nothing sort of falls through the cracks there. But the whole idea is like in that moment of need, you can pick up the phone and you've got the same doctor you would see in the ER, but instead it's in the comfort and safety of your home. We have an 85% emergency department diversion rate. What that means is 15% of the time you may have to go. If you do go, we will call ahead of time and let them know that you're coming. You know, I practice at Northside Hospital. 2 of my colleagues are from different hospital systems, so I'm a little biased, but I really like Northside Hospital. So I'll oftentimes send you there unless you get all your care elsewhere. And it's not to promise you that you cut the line, because in the end of the day, if there's someone who's dying, they'll always take precedent over. But it's always nice to have someone who's already assessed you and say, like, this person's oxygen level is low, these are their risk factors, and you almost know, it's basically giving the ER doctor there sort of like a report on a platter about what to do next. So that's us in a nutshell. Thank you, Mary. I'm really bad at marketing, so. Any other questions or, yes?
Now, if you have your internist or concierge
Yes,
doctor.
yes.
Your services are still useful
Yes, exactly, because we're a different specialty. So think about your primary care doctor is all about like your foundation and like, I don't know, this may not be a great analogy, but your primary care doctor is like the guy who fixes the foundation in your home, and we're more like the roof. And there's a little bit of overlap. You can say like, something doesn't look right or whatever, but we're just a different specialty entirely. So what a primary care physician is comfortable managing as an outpatient is usually sort of at the end of their risk spectrum. And for us, it's something we see regularly and discharge from the ER. So it's just having another type of doctor available to you. And again, this is a doctor that the majority of Americans see multiple times a year. And for some reason, you don't have access to them, which is such a wild thing to me. But that's what we're trying to fix.
Coordinate it with these doctors. That's
exactly.
It doesn't matter what you have.
Mm-hmm.
You coordinate it, and you're like you fill the gap.
Exactly. Yes, we're the gap filler,
Yes.
essentially. Yep. And half our work is really coordination of care. So yeah, absolutely. And then yes, ma'am.
Yeah, is it a fee for, like, I understand you have to pre-set up so that when we call, we're not strangers, but it's
Yes.
a monthly fee, an annual fee, we'll charge you once you have to call us, how does that work?
Yeah, so we have a monthly fee. It's a subscription fee. So it's $149 a month. And then thereafter you can cancel. So it's a minimum of 6-month subscription, and then you can cancel thereafter. But if we avoid one ER visit for you, that pays for the cost of service for about 3 years. So we think we're pretty cost effective in the marketplace, but you guys tell us. So, and yes, ma'am.
I was just at Publix the other day, and the pharmacists are really very helpful. They offered the pneumonia vaccine. So you can walk into any Publix and say, I want the pneumonia vaccine. Or if you're going in for other medication, you're picking it up, they will probably suggest it.
Yes.
So it's as easy as that. That's it.
Thank you. Yes, ma'am.
I'm just curious, you were so helpful in giving other things I hadn't thought about, and other ways to look at some of the UTIs or things like that. You mentioned like the podiatrist and things like that. So when I think of UTIs, I think of urology. When I think of falls, is there any an ENT? Could it be a balance issue? Are there neurologists? Are there anything else? Because I think a lot of us have kind of a wide scope of doctors that either we have or our parents have.
Mm-hmm.
Anything else that we should?
Yes.
If I'm trying to get ahead of these things happening.
Absolutely. So it depends. Most primary care doctors are very capable of managing dizziness, vertigo, and they can check a B12, a vitamin D, an RPR. They can do all that screening and then refer you to the next appropriate specialist. Podiatry has a really low barrier to entry, and oftentimes, to be honest with you, we're not trained very well on feet. So I usually will say just see the podiatrist. But for ENT and neurology, I think that if you have a loved one that has history of dementia, they probably already see a neurologist. But a PCP is kind of can manage that first round of it. Or same with us, if you reached out to us and we assessed and we thought, there's actually a disequilibrium problem here, then we'll refer you to vestibular physical therapy, for example. But you could totally go see ENT and all that. I just worry that it may not be the best use of time because, it's hard to go there and you got to spend all day. And then now we have to pay for parking. It's a weird thing in Atlanta. So we've got all this space. I don't understand it, but. Absolutely. Well, you guys, thank you so much. Yes, ma'am.
Back to the UTI thing. What about the UTIs that just don't go away? Because you mentioned that a lot of people have bacteria in their urine. So my mother is dealing with, this is her now 3rd round of antibiotics that she started, and they're doing a culture and all that kind of stuff, but it's just not going away.
Mm-hmm. Yeah, so.
She's seeing a urologist. This isn't through her PCP.
Got it. Okay.
Why
Right. So the question is, one, is it really an infection? Is it just bacteria that's just lingering there? And then 2, okay.
Except
well,
the kind of being tired and but part of that is just her.
Okay. Has the urologist done a cystoscopy where they look in?
They were going to, and then she said no, but now that's on
okay.
the books, so yes.
Okay, because that would be the next step, is to actually put a camera in the bladder and see, is there something growing in here? And we had a case like that where it was like a ball of fungus. It wasn't even, and it was just living because urine that sits becomes an area for anything that sits. Just like still water can get infected, it's the same concept. Or gross stuff, same concept. So the next step would be a cystoscopy to see, is there something in there that's causing that? And then after that, if that's not the case, you treat the infection, eradicate it, and then they'll likely put her on like suppressive antibiotics. And then it's really just a risk-benefit discussion, right? Because if you're on antibiotics all the time, then it causes diarrhea. It can give you something called C. diff. But if the alternate is agitation and, fevers and sepsis, then, this is better than that. But, nothing is without its risk. You kind of pick your poison as, for better or for worse.
An infectious disease, right, to help?
Yeah, if the urologist can't manage it. And that's where it's like, you do as much as you can with the urologist, and if they don't have the answers, you can move on to infectious disease. Or if you feel like they're not doing enough for you, like in the end of the day, like doctors are people, right? Some people you trust, some people you don't. They don't, so you can go see someone for a second opinion. You can see infectious disease. You can even see your PCP, who can also help manage these things. It's just a matter of picking like one and sticking with it. And then if you decide to move, then move everything over. So that way you don't have like a bunch of hands in the pot. And suddenly your mom's on 5 different medicines and we don't really know what they're doing.
Thank you.
Yes, absolutely.